Is it broadcasting?
We don't
Broadcasting.
I know, but we don't have the picture. Okay. Okay, we will get started. I'm not sure that you've got a picture to see, which our tech team are trying to put right at this end. My name's Eardley. I'm a council member of the Royal College of Surgeons. I'm a consultant urologist from Leeds. And I'm sat here with Ian Martin, who's a consultant maxillofacial surgeon from Sunderland and is the council lead for the surgical care team. And Bradley Russell, who's a surgical care practitioner from the Royal Marsden. Pictures. I hope you can see the pictures because we're now seeing them. Bradley Russell, who's an RCS associate member, but is a surgical care practitioner from the Royal Marsden. And over the next 20 to 30 minutes, we're going to take you through a presentation relating to the surgical care team, following which there will be opportunity for you to ask questions electronically in writing, which we will try and answer with a prompt finish time of 7 p.m. On your computer screens, you have the ability to vary the size of the slide and the picture that you're seeing, which you'd be able to adjust yourself if you want to minimize us and maximize the slides or vice versa. So the first thing I should emphasize is that the Royal College of Surgeons of England has really is committed to supporting the surgical care team. This is a relatively new development for us, and it reflects our wish to use the broader surgical team with their different staff, with the different skills that they have to support surgical care in the UK. On to the last slide.
You take me to the last slide. So I will slip you back to the beginning slide. There we go. I guess the reason that the college is supporting the surgical care team is because we believe for patients it will improve the quality of their care, it will improve their experience, and it will also improve patient safety. I think members of the team who work in such teams feel that it's helpful for the members themselves, whether that's consultants, trainees and the SAS surgeons. We believe that the increased use of the surgical care team will enhance the training of junior surgeons, and that the extended roles will extend not only in the theatre area, where perhaps as surgeons we feel that might be appropriate, but also might include perioperative staff. So who are the surgical care team? This little cartoon, I think, will take you through it, and many surgeons will be familiar with some of these people. So within the operating theatre is clearly the anaesthetist, but they are now often accompanied by people who are called physician assistants in anaesthesia, who may well be giving an independent anaesthetic. I, for instance, do a day case theatre list where I'm often the anaesthetist is a physician assistant anaesthesia supervised by a consultant anaesthetist in an adjacent theatre. Within the theatre itself, there will be a consultant, possibly a surgical trainee, possibly a surgical first assistant, and possibly a surgical care practitioner who may be undertaking different roles within the operation depending upon the case and the location. The surgical care practitioner works not only in the theatre but also preoperatively and post-operatively, and in different hospitals will follow the patient all the way through the pathway.
When you get to the ward, certainly in my own hospital, we have a lot of advanced clinical practitioners and some physician associates who work with us both on the ward and in the assessment areas in order to improve patient care and enhance the pathway through that. In some departments, physiotherapists with an enhanced role are also contributors, as are prescribing pharmacists. And this change from being an environment which is in many ways was medical only for many years, I think has changed for many of us, so that this broad team, the surgical care team, now provide the care for our patients. The first real substance bit of the presentation relates to some work that the college has been doing over the past 2 to 3 years to investigate the experiences of staff and of patients who were treated by units where the surgical care team was already in place. In part, this was initiated as a consequence of trying to identify those aspects of a junior doctor's job that perhaps were not directly relevant to training, to develop ideas about what other members of staff could undertake, some of those tasks that traditionally have been undertaken by doctors. And it led to the production of this report, which is available via the website and can be downloaded, which was initially published in 2016, called A Question of Balance. At that stage, we were calling it the Extended Surgical Team. I think we were of the view that a more inclusive terminology is the surgical care team, because I think that more accurately describes the breadth of the people who are part of the team. The tasks of the report were really to undertake a task analysis of junior doctors to identify which bits of their job could potentially be done by other members of the team. The second objective was to understand the competencies of that team and to try and work out what different roles there were and how they could fit into a team, perhaps what one might call a modern surgical firm. And then to explore different models of that firm as they've been introduced in different parts of the country, in order to understand better the ways in which team working could enhance the quality of care for the patients, and also to explore the ability to improve the quality of surgical training. To that event, part of what we did was we went on a number of site visits to different units around the country, which are shown in the slides that you can see. And we aimed to go across the whole of the country from the north to the south and to explore different specialties and to identify what those different specialties had done to broaden the breadth of the team providing care and to identify what benefits that brought to patients and indeed to other members of the team. I haven't got time to go through all of those, but we'll just pick out one example, and that's St George's. St George's were really one of the pilot sites for physician associates 10, 12 years ago, and have been training physician associates who work quite widely in the different specialties in that hospital. So as you can see from the table, there are physician associates who, at the time we did the report, were working in breast surgery, trauma orthopedics, neurosurgery, pediatric surgery and neurology, and they were ward-based and some theatre work, particularly involved with the clerking and assessment of patients, undertaking a fairly minor procedures on the ward and discharge planning, and they would work alongside and sometimes interchangeably with the junior doctors. In other parts of the hospital, advanced nurse practitioners and advanced clinical practitioners had a similar role, for instance in general surgery, while specialist nurse practitioners supported other specialties, ENT, oromaxillofacial and plastic surgery. And you'll see from the table that in some places they were providing 24/7 on-call cover at night with senior cover from home. And this model of advanced practice providing on-night on-call service is not peculiar to those specialties. It is the norm for many cardiac units up and down the country. What we found was that the experience, both from patients and from other members of staff, was overwhelmingly positive. It provided better continuity of care for patients. It provided better quality of care for patients. It often improved efficiency of the patient along the pathway. And in most places, indeed, talking to the trainees, it enhanced the surgical training because it often freed up the junior doctors from some of those tasks on the ward and allowed them, from a surgical perspective, to get into the operating theatre or into the outpatient clinic. Not a perfect picture. There were some issues around accountability, around career progression for this workforce, and a particular issue about governance and how they fitted in and who they answered to in terms of their governance, because many came from a nursing or advanced practice background, but felt that they were more appropriately be managed and governed within a medical environment. Given the small numbers, there are also concerns about sustainability and the concern that if a service became too dependent on one or two people, that service may be at risk if that person moved on. So certainly some problems that needed to be changed and improved, but it was that report that really set forward the piece of work which Ian Martin will describe to you about how the college wished to engage with that workforce.
So, phase 2 of the college's work in this area really can be broken down into the areas that you see on the slide. So, guidance and support for the surgical care team, a number of resources and templates, and creating an environment within this college for members of the surgical care team to find their professional support. I think it's probably worth saying that, you know, my background as a surgeon up in the north, I'm also a medical director, and one of the things that I have found is a degree of apprehension, I think, among surgical teams about going it alone and developing this. So I think quite rightly the college has decided it has a role to provide support in the ways outlined there. And I'll just move on to talk a little bit about this document, which I think is very important. It's been generally well received, but it's an attempt to try and give that assurance to employers, to those wanting to be involved in the surgical care team, that that this is a properly supported professional development, and that they're not going it alone. And it gives quite a lot of guidance about the things you need to think about to set this up, and some of the nitty-gritty about actually implementing it, which is has to be thought about carefully. So if you're introducing a new surgical care team, you need to think carefully about the care and staffing models that you want to implement. And quite a lot of that will be driven by some of the inevitable deficiencies and difficulties that surgical, old style surgical firms, which are referred to in the study document, no longer exist in the way that they did 20 or 30 years ago. So we've got to start to look at how we deliver high quality surgical care with all the restrictions that we now have to work within. So it means we've got to introduce new models of service. And to do that, we need to plan, we need to consider very carefully recruitment to make sure that the process of recruiting is adequately robust and we get people with the correct competencies and training to actually undertake the roles that we want. Line management, supervision has been an issue that I think has raised concerns, but we're very clear as a college that these are members of the surgical care team, and like any other member of that team, they need to be accountable ultimately to the consultant surgeon who has overall responsibility for the care of those individual patients. And clearly there needs to be a risk assessment done locally based upon the competencies that one anticipates these individuals will deliver. In most organisations, there will already be clinical governance structures which allow for that sort of development. In my own institution, it would go through the clinical governance steering group and up through governance committee, ultimately to be approved by board. But that will vary, of course, from place to place. And the sort of things that you need to think about are scope of practice, whether that's in the operating theatre. Liability has been an issue in general terms, provided you have competent individuals, well recruited, by a good process, and that they are working within a clinical governance structure to scope of practice which is approved. They'll be indemnified in the same way that any other member of staff is within that team. If you're going to employ surgical care team members outside of the NHS, that's a different matter, and you do need to be go into detail with your own defence association about how that will be covered, or with the institution, because it is different. So there's caution, but there's something about that in this document. Accountability and management, working with consultants and trainees, and it's not just one-sided. Trainees, and I think it's fair to say some of the trainee groups have expressed concern about the potential impact upon their training. They should take comfort, I think, from the document that Ian has just gone through, because overwhelmingly in that document, the outcome was that the quality of training that trainees experienced was actually beneficial. And so I think that's something that needs to be worked through with trainees, so that they are reassured that this is actually going to be for their benefit as much as for the benefit of patients. There are issues about whether patients have the right to be refused treatment, and we're very clear in the document that patients need to know what the individuals are, what their background is, not in detail, but in broad terms about whether you're a doctor or not a doctor. And in the same way that any patient can refuse to be treated by a consultant, they can be refused to be treated by any other medical member of the care team as well. But in the vast majority of cases in the study, that was not an issue for patients, provided they knew the scope of practice of the individuals concerned. And importantly, and part of the role of the college as we see it, is to provide that environment for the professional development and career support for individuals pursuing a career in this area. Clearly, many of the practitioners other than PAs are currently responsible and accountable to their own regulatory authority. But that only covers them, and they're only accountable for that up to the code really of their core professional competence. So there is a need, as we see it, for the college to give guidance in this area. And again, a lot of that is found in this document, which I hope you'll find helpful. And there are a number of templates there to business plan, to provide job descriptions in a model format to help develop and think about the things that you need to prepare in order to develop a surgical care team. So I'm going to hand over now to Bradley. Bradley is a real surgical care practitioner and can tell you about what it's really like on the ground.
Thank you. Thank you very much. And before I begin, I'd just like to extend my thanks to the Council for inviting me here today. So really, I provided a few slides here just to really talk about my background and how I sort of came into the role, and really how my role fits in with the day-to-day running of the urological firm. So first and foremost, I qualified as a nurse back in 2011. Back in 2009, I'd had a 2-week placement at Bart's Hearts in theatres, and I was absolutely dreading it. I thought, oh, I'm not one for gore, but I found it an absolutely tremendous experience. I got to meet and shadow a trainee surgical care practitioner, which really sort of ignited my sort of fire and passion behind this sort of role, and drove me to pursue a career in theatres. So consequently, my first nursing role was as a scrub nurse at the Royal Marsden. I was then able to pursue a surgical first assistant training post, and this was really because robotics had began to sort of take off, and the dual console had been released by Da Vinci in the robotics field. But quickly it was realized that the scope of practice that a surgical first assistant had didn't allow me to provide the sort of patient side assistant role competently. For example, placing WEC Liga clips onto vessels and bundles when sort of nerve sparing. So therefore, I was able to, along with my consultant mentor, able to drive forward a surgical care practitioner post, which was a business plan was put together by the nurse consultant for urology and the business manager, and that took place at Anglo Ruskin University. It was a 2-year course that was in my second year accredited by the Royal College of Surgeons, and it really sort of helped me provide that sort of competent assistance really at the operating table, as well as extend my scope of practice outside of the theatre domain. I completed my training in March of this year, and really have sort of been able to take my skills forward on a day-to-day basis. But really the main driver, as I alluded to earlier, was that we were having sort of senior registrars and senior fellows coming to the trust to learn how to undertake robotic urological procedures, and they'd often find themselves in the patient side assisting role. Therefore, there was scope and a business case there for a patient side assistant, a surgical care practitioner. So sort of really my role enables these senior surgeons to get onto the dual console and be able to learn and train under the guidance of the consultant surgeon on that dual console. My sort of day-to-day assisting isn't solely tied to the robots. I also assist for open surgery as well as laparoscopic surgery. And again, this allows the trainee surgeon to lead the surgery with me assisting whilst the consultant is there giving sort of proximal supervision. I know there's many junior trainee surgeons out there that know that one of the best things is to keep the surgeon outside of the consultant surgeon outside of the sterile field, so they can learn and go forward without the consultant stepping in to take over. There's also, I provide a continuity in regards to sort of consultant preferences, for example, sutures and sort of the way that they do particular areas of their surgery during a certain case. So it's important that in my role I understand the steps of the surgery, as well as sort of noting if there's any areas or any concerns going forward. So this is just a quick slide really just to show sort of what the urology team is made up of. It's made up of obviously consultant surgeons. We have a nurse consultant as well, and we have a good cohort team of advanced nurse practitioners that tend to take care of the sort of day-to-day running of the ward. The vast majority of my day-to-day workload is sort of, I'd say 75% is sort of theatre-based, but we'll come on to what else I do outside of theatres. I work at a cancer hospital, therefore we do have a fantastic team of clinical nurse specialists that end up sort of being the liaison to patients and sort of act as that conduit between patients and their consultant. Again, healthcare assistants are vital, we find, in our day-to-day running, especially in the clinic scenarios. And of course, there's me as a standalone surgical care practitioner at the moment in the urology team. And as I mentioned earlier, we tend to have senior surgeons sort of ST5 and above. So I'm able to help facilitate their training by undertaking the sort of junior surgical role without impacting on junior sort of surgeons training. Out of theatres, I undertake urodynamic investigations, and again, a healthcare assistant is vital during those procedures because they help turning the room around, and once I'm talking to the patient as well, they're able to insert catheters in certain scenarios as well. Patient educations for robotic prostatectomy, so we invite any of our patients who are going to undergo a robotic prostatectomy to attend a patient seminar, a patient sort of educational tool, and I help deliver that again with a clinical nurse specialist and a physiotherapist. Of course, being urology, we also take care of the male catheterization training for nurses and other allied healthcare practitioners within the trust. I also take part in audit and research, and once a week I attend an outpatients clinic.
Okay, we now open for questions. I think if you type them in, then they will be shown to us on the screen and we will try to answer them as they come up. So the first one is, as a surgical care practitioner, how do you think the role has changed now that the wider surgical care team has become more established? So Bradley.
Well, as a newly qualified surgical care practitioner, I mean, as you saw in my slides, I mean, we do have a very mixed and diverse surgical care team that I work with on a day-to-day basis. I mean, my role sort of per se hasn't changed a great deal, but like I said, I've only been qualified a few months. But it's good to see that people like the Royal College of Surgeons are stepping into the domain and embracing us as sort of as part of the wider surgical team. But that's sort of really as much as I can really sort of put on that sort of question.
And I think one of the issues is it not that this is all pretty new
Yes.
to many of us,
Yep.
and it's really in development. And I think one of the things that comes out of the report is the different way in which surgical care practitioners will be used in different specialties, in particular different specialties and different types of hospitals. So Bradley's in a highly specialised cancer hospital, and what you've heard is how they've deployed them. But of course, in a more general hospital with more sort of general surgery, less specialised surgery, they may be used in a different way. I think the important thing that comes across is that they need to be intimately involved in the team, not just involved in very highly focused tasks. I think that's what comes out of that study. That's when they're best deployed.
No, I'd agree on that. Certainly the sites we went to, very different, very diverse in both location, size of hospital, the absolute clinical problem. The solutions had been developed by local surgeons, largely dependent upon their local problems, and that was very variable. So you do get some members of the team who work purely in theatre. You have others who work purely in the ward. You have some who work across the whole length of the pathway of the patient through the hospital, and that flexibility is, I think, important. What's also important is that as part of the team, they have the support from a senior surgeon should they need it, whether that typically would be a consultant who will be initially part of their training, but will also provide the oversight to the clinical care given to the patient. So
Well, Ian, do you want to take that? Because you're very familiar with the document. Looked at that.
So the question is, as a foundation doctor, how will my training be impacted by the surgical care team? How will it be different to foundation doctors before me? The first part of the report, which I didn't show to you, was the task analysis of core trainees and foundation trainees across 3 deaneries: KSS, East Midlands, and Yorkshire and Humberside. So we got about 990 trainees who answered a diary exercise recording what they'd done on the previous full shift on which they'd worked. And rather depressingly, we found that as a foundation doctor, they'd been spending 3 or 4 hours each shift undertaking what was essentially administrative work. Now, some of that administrative work is important to patient care, and an accurate description of what's happened to a patient at the time of discharge is important. But the amount of time these junior doctors were spending doing that was clearly inappropriate, and in many cases not valuable to their training. We'd expect that with the enhanced or the surgical care team development, that those tasks will be shared more appropriately, so that the junior doctors can spend more of that early stage of training, perhaps going to the operating theatre, which is what I used to do when I was a houseman, or going to the outpatient clinic, which again is what I used to do as a houseman. What's happened over the years is much of it's probably mundane is probably the wrong word, but it sort of describes the sort of work that historically or increasingly has been done by foundation doctors. With the development of the surgical care team, I think that will change, and I think that as we move forward, foundation doctors will find their life changes. I can give you a practical example that we've introduced in Leeds as a consequence of this report, in that we've employed something like 12 to 14 advanced practitioners who support the surgical assessment unit and the ward care of patients, and the uniform view of our foundation trainees, and indeed their responses back to the local deanery, is that their life has been enormously improved by the introduction of this workforce.
And I think it's important to say that the college has been concerned by the feedback through GMC surveys, deanery surveys, of the relatively negative views of foundation doctors in surgical posts by comparison with other specialties. And of course, let's be perfectly honest about it. We're here to promote surgery. We want to encourage junior doctors at foundation level to want to go into surgery. So it's in everybody's interest, particularly the colleges, to give you a good experience in surgery so that you actually want to pursue that as a career.
I think it's also important that the surgical care team is designed appropriately to fit the service provision that needs to be facilitated. You know, I don't think we're not saying that every firm has to have a surgical care practitioner, or any other sort of member of the wider surgical care team. These are the roles that are available to departments should they find that these roles would fit nicely into their day-to-day service provision.
I think that's a really important point, and really came out of the report, in that each of the different units that we visited had slightly different problems which they solved in slightly different ways. And I think the way around this is not simply to appoint a whole group of advanced practitioners and find them a job to do. I think you've got to look to identify what the problems are, and then identify the workforce who can perhaps help to solve those problems. So,
well, I think I mean, this is the document that I alluded to. I mean, I think is a really good start. So what I would suggest is you direct your surgeons first off to look at this, and to look at the case for change document that Ian's talked about, because those, I really do think, spell out some of the problems that people have seen and worked through to get the surgical care team to actually work effectively. And this is a very practical document. It helps people understand how, going from nowhere, you can get to a position of actually implementing this, and the sorts of things that you need to think about to plan this carefully, so you actually recruit the right people for the right team in the right circumstance. So my answer would be, print a copy of this off, it's PDF, you know, freely available on the website, and take it to them and show, well, actually, you know, it's been done, and this is how we could do it.
Yeah, absolutely.
I mean, I had, as a scrub nurse background, I had a sort of an existing role, existing relationship with the consultants in my team. But I really found that, I know this isn't the same for everyone, but during my training, I learned especially a lot from the senior surgeons, you know, senior trainees and the fellows, really, because I'd be able to facilitate part of their training, as I mentioned earlier, on sort of something like undertaking the patient side assistant role. And therefore, they'd be sort of taking me through the steps to sort of close fascia, to do a primary closure in other procedures and operations. So I mean, really, it's making sure that also your consultant mentor, your consultant supervisor, is also being a sort of advocate as well within the sort of wider surgical team, to ensuring that you're getting the right placements and exposure as part of your training. But of course, wherever you can support trainee surgeons, then that's obviously a vital part of your role going forward.
I think there's one other point that probably should make. All surgeons will be familiar with the 4-monthly or 6-monthly change of their junior staff, and having to, on many occasions, retrain the junior doctor or get them used to the environment in which they're working. One of the advantages of the surgical care team is that there's greater continuity, and actually they can provide some of the support to the junior doctors as they come through, and they can help them adjust to the new job. They also provide some continuity for the more senior surgeons, which certainly we've found to be very useful when it comes to the care of patients on the ward or in the assessment units. What's our next question? This is an interesting one. The question, those who can't see it, should surgical care practitioners be recruited from within other ranks, such as nursing in the hospital, as a primary profession from university with a science degree or A-level or GCSE? At the moment, the routes of training are quite different. To be a surgical care practitioner, as Bradley's described, you have to be a nurse or an ODP before moving on to doing that master's degree. Physician associates, which are a separate and different group, but actually are probably the coming workforce, because there's going to be far more of them, are people who essentially just have a biomedical degree and can go straight into doing a 2-year diploma course after that initial degree. Both routes are currently open, and as some of you will know, the government recently announced that the physician associates will be regulated in the near future, probably by the GMC. So some of the concerns that have been around this direct entry to being a physician associates, I think, are being alleviated. And there's another issue that's relevant to the workforce. Many surgeons say, well, I don't want all the nurses on my ward to become advanced clinical practitioners because we don't have enough nurses on the ward, and that there's the potential to rob Peter in order to pay Paul. To them, the physician associates have been a very attractive extra workforce that can supplement the workforce problems that are being suffered by many hospitals up and down the country without depleting the nursing workforce even further.
I think it's also crucial to point out that I think, excuse me, these roles help in the retention and recruitment of staff going forward. I mean, I know traditionally, coming from a nursing background, that the way to make your march through the bandings has normally been sort of via a managerial route. I think that the benefit of these sort of advanced clinical roles means that an individual can grow within the clinical environment rather than sort of being steered more towards the managerial one, should that be the case. And also you can be a physiotherapist as well and become a trained surgical care practitioner. I don't know, there'll be physios who I trained with that'll be screaming at the laptop. But yeah, so I think it's a vital tool really for recruitment and retention going forward as well.
The physiotherapy one is quite an important issue because there are some, particularly orthopaedic units up and down the country, that have used physiotherapists in advanced practice roles to support orthopaedic care in the way that you described for general surgery and neurology.
Yeah, and I think the physicians associates have got a really important role potentially. Looking after the medical aspects of care for not just orthopaedic patients, but for the wider surgical community. There's been a lot of success, demonstrated by introducing orthogeriatric care using nurse practitioners, advanced nurse practitioners, and other doctors for orthopedics. We did that in our own unit because we had, quite a high mortality rate at the time for fractured neck of femur, and one of the parts of the action plan to deal with that was to introduce a proper and comprehensive orthogeriatric support. But with those same complexities medical comorbidity complexities exist in all branches of surgery, and particularly if you've got sick general surgical patients, increasingly it looks like that sort of support that's traditionally gone into orthopedics would also be of benefit with other branches of surgery, particularly general surgery. So physicians associates could certainly have a role as part of the wider surgical care team there, even with their current level of training and the restrictions on them. Perhaps you, Bradley, because Bradley started off as an SFA.
Yeah, I mean, I'll read out the question. As a current SFA in training, so surgical first assistant, and a clinical nurse specialist, do you anticipate the role of the SFA evolving further with further extended skills in addition to the new PCC statement? Yeah, I mean, that's an interesting and a great question. I mean, I know that the PCC statement was re-released this year in 2018, which is built on the existing one from 2012, and it had an extending roles element to it, which was skin suturing, application of diathermia for hemostasis, and I think it was retraction sort of deep within the body cavity. I mean, I think, so as I mentioned earlier, I ended up sort of transitioning over to getting onto the surgical care practitioner pathway purely because the skill set that I had as an SFA wasn't really there to meet the needs of the day-to-day surgical list. And also I wanted to extend my skills outside of the theatre domain. I mean, so they have extended the role, but it's where do you draw the line? Where do you start in sort of encroaching on the role that the surgical care practitioner sort of undertakes? I know the surgical first assistant role is quite popular in Scotland, so north of the border. But speaking again from my own experience, I felt that I wasn't able to assist in a fully sort of competent manner for the surgery that I was being exposed to on a regular basis. So, in conclusion, really, I think that the new PCC statement has outlined key parts of any assisting role, definitely sort of closing of skin after an operation. I think that's vital, and of course administering local anaesthetic. Again, the operating surgeon has to be within the theatre. It can't be under proximal supervision. They can't sort of do the primary closure and then sort of then walk off and leave you alone in theatres. But I mean, it's really making sure that your role, your scope of practice fits the day-to-day tasks that's expected of you in theatre and outside of the sort of theatre domain, really. But as I said, I know it's been newly refurbished, the new position statement of 2018. So I can't see them changing or developing the scope of practice much more anytime soon. I mean, yeah, so really, so the question for those who can't see, there seems to be an ongoing trend for surgical first assistants to be required to work beyond their scope of practice. How can this best be addressed? Well, again, so that's how I ended up becoming a surgical care practitioner, because really I was constantly hitting the limits of my scope of practice as a surgical first assistant, which I know is frustrating, having been there before, frustrating for many surgical first assistants. So really, I was in a position where I could, speak to my consultant mentor, the consultant supervisor, and say, these are the, if you want me to do X, Y, and Z, then this is the role that I need to be training to undertake going forward. And of course, new documentation like the surgical care team guidance framework is excellent evidence to help support that development. So I really would use the resources that the Royal College of Surgeons has available to help take that role and expand that role and develop it further as a surgical care practitioner. You show it to your consultant surgeon, show it to your business manager, show it to your matron if you're still in theatres, which you would be as an SFA. Then really try and sort of get something moving forward, putting a business plan together. And I believe there's a template in the surgical care teamwork guidance framework. So yes, it is available online, and check it out and see if you can take that forward. Good luck.
Right, I'll read this question out. If original financial models justified the team expansion through, I think that's filling rota gaps and thus saving excessive expenditure, what kind of models are used to finance the various roles outside of the on-call rota? Well, I mean, I think from my own experience, one of the issues that we have is using a lot of very expensive locums. So, not just for the on-call, but actually, for filling chronically unfilled rota gaps. And one of the things I think you need to get surgical teams to recognise and come out of denial about is that some of these chronically unfilled posts are not going to be filled by registrars, coming over the horizon in their droves. That is not going to happen. So you need to look at a proper business plan for how that fits into a surgical team. But I think it's important that, as we've said, that's a surgical team thing. It's done in a planned way. It's not used just to fill gaps. So what you want to do is a proper redesign. And I come back to the guidance framework that gives some templates which you can use to try and articulate those discussions about how you need to restructure your team to make sure that you're meeting the demands of the service. And where it's been done, broadly speaking, this is not a money-saving exercise, but it ought to be more or less resource neutral.
I'd fully endorse that. The best data on that really comes from Derby, where they've clearly demonstrated that the surgical care team, in large part, has been funded by locum spend, by the spend that the trusts are having to make on locum doctors. And if you philosophically take the view that a surgical care team member can work interchangeably with junior doctors, and I'm talking about junior doctors at foundation level and at early core level, then there is the opportunity for pretty even costs for the hospital. Everybody recognises that cost is a significant issue for the trust, and indeed in my own trust it was a serious barrier for some years
to the employment of this workforce. But once that penny drops, it is interesting how trust managers are more open to this approach.
I think we had this question already. I think
we've seen that question before, I think. Okay, so I'll take this one. How can I get more involved with shaping the work of the college and in developing these roles? Well, if you're part of the surgical care team, we want you to join, and I'll come on, in a few minutes when we've had the last of the questions, just to briefly show you how you can join. This is a new thing for this college, so I would encourage you to get involved, at the outset, so that you can start to shape that. And very shortly, once we get a sufficient cohort of surgical care team members into the associate role as members of this college, we're going to be establishing precisely that, a group which actually will help to define what you need from this college. So the short answer is join up. Okay, so I think that concludes the Q&As. And as I just alluded to in the last question, associate membership did open in April 2018. And as I've also said, we're shortly going to be establishing a working group to help shape that associate category and what you need. And welcome to membership. As you can see, the membership benefits: you get access to our courses, online facilities, and as I say, I hope you will want to shape the future of that group and join in. For a limited time only, there's a reduced membership fee. I think it's on the next slide. The next slide. I think it shows you. Hopefully, yes. So if you go to the website, you can join up for £75 in 2018, and I hope in addition to that, you'll want to join in a conversation after this on Twitter and really get involved. So it is a great opportunity to be in at the outset of the college's endeavours in this area. So I hope you'll all feel that that's something you want to do. Just before I go, the college is doing a number of road shows across the country, looking at quality improvement focus groups, and the dates and venues are shown on the slide there. The London, Manchester, Cardiff. There's going to be one in Exeter. There isn't a date for that yet, but it'll be on the website soon, and Newcastle. These are great opportunities to share in your quality improvement endeavours and share with other people theirs as well. And the college is trying to collate all of this to make sure that best practice in QI gets shared as widely as possible. So I hope you'll take the opportunity of joining in some of those. Well, finally, I'd just like to thank you all for taking the time this evening to join us here. I hope you found that of benefit. I'd like to thank both Ian and Bradley and the team here for setting this up. It's an exciting and new departure for the college to get involved in this area, and I hope you'll join us as members and make that a big success. Thank you very much.
Thank you.